Welcome to Beat Cancer, the official podcast of the UC Davis Comprehensive Cancer Center. Thanks for joining us today as we have in-depth discussions of the science, research, and advancements taking place at our National Cancer Institute designated Comprehensive Cancer Center. I'm Chris Joyce.
And I'm Stephanie Winn. We will also examine proactive approaches to cancer prevention, and most importantly, how we are breaking barriers to beat cancer in our community and beyond. Dr. Jonathan Riess is with us today. He's a medical oncologist, director of the Thoracic Oncology Program, and associate professor of internal medicine and hematology and oncology. Welcome, Dr. Riess. We're so glad to have you today. You certainly have taken on a challenging set of cancers, thoracic cancers, and namely we're talking about lung cancer, very difficult to treat, and they're very difficult to diagnose as well, right?
Yes. So thanks. First of all, thanks so much for inviting me to speak on this podcast. Really appreciate the invitation. And so, yes, we at UC Davis Comprehensive Cancer Center have a very active thoracic oncology program that focuses in lung cancer and other cancers of the chest, where we have a great multidisciplinary team of medical oncologists such as myself that focus in thoracic malignancies, as well as radiation oncologists, thoracic surgeons, and interventional pulmonologists, as well as a group of great supportive care oncologists and other folks that help us take excellent care of our patients and provide access to cutting-edge research and clinical trials.
And I understand one of the biggest challenge is getting potential patients in for screening. 80 to 90% of lung cancers are caused by tobacco, right? But we only have, a 1% screening rate here in California. Only 1% of eligible patients, these are primarily smokers or past smokers, are coming in to get screened. Is that frustrating that you're not able to get in there to diagnose these cancers early?
Well, of course, the best way to detect cancer is to detect it early. And so I would urge, patients who do have a history of smoking to talk with their primary care doctor and other healthcare providers they see to see if screening is right for them. So, it's basically a way to use low-dose CT scanning to try to detect lung cancer early. And so, we go by certain age and smoking history and other risk factors. But I think it's important for patients to know about it and to discuss it with their healthcare provider to see if it's right for them, because by detecting things early, that could really make all the difference.
Well, what about non-smokers or people that have never smoked? I mean, first off, can they get lung cancer? And then if they can, how do they go about even figuring out signs and symptoms so that they could talk to their doctor if maybe they need to be screened as well?
So that's a great question. So right now, there's about 20% of lung cancer actually occurs in people who don't have any history of smoking.
Wow.
And right now, there's not any current guidelines about who to screen for lung cancer in patients who don't have a smoking history, but it's something that's an area of active research. And I would just highlight that, I would highlight, as you point out, that lung cancer can happen in people who haven't smoked. So to not ignore symptoms, even if you don't have a smoking history. And the other thing I would emphasize is that we're learning more and more about lung cancer in non-smokers and in smokers, and oftentimes there's some differences. And so there's a higher percentage of folks who get lung cancer who don't have a smoking history, who have special mutations in their lung cancer that allows us to give precise targeted treatments, often with great benefit in terms of really knocking the cancer back and helping patients live longer and live better. And that's an area that's a huge amount of research here at UC Davis in terms of clinical trials and preclinical research. That's one of our major focuses, is how to best come up with treatment options to target those mutations that act as like an on switch. It basically it's like when you're turning on the light. What it does is it basically turns on the cells to constantly divide and leads to cell growth. But we've got great off switches for a lot of them, and the ones that we don't have great off switches that are FDA approved. Oftentimes at UC Davis, we have clinical trials to try to find those off switches to really shut down the cancer. Another area of active research at UC Davis is immunotherapy, and some patients with those non-smoking mutations may not benefit as well from immunotherapy. So we're looking for ways to help improve that. But immunotherapy has revolutionized how we take care of lung cancer patients, both in early stage, accompanying potential surgery and chemotherapy, and later metastatic stages. I mean, that's been another tremendous advance where UC Davis has really led the way. We were one of the best accruers in the United States in terms of patients coming to UC Davis and going on the initial pembrolizumab clinical trials that then were later approved and just provided tremendous benefit to patients. And we were able to offer that to our patients early. And so now that those have been approved, we're looking at combination therapies to overcome that resistance to immunotherapy that can develop or forestall it. So those are some of our major focuses at UC Davis of how we can bring cutting edge research to patients.
What treatments or what is there a particular clinical trial that you think holds the most promise for these patients in the future? What are you most excited about in this area, particularly in immunotherapy?
So that's a great question. In terms of trials that I'm excited about at UC Davis, as it pertains to immunotherapy, I would highlight our lung master protocol that we're really excited about. It's sponsored by the National Cancer Institute and is a public-private partnership where what we do is provide gene profiling of the patient's tumor free of charge as part of this clinical trial. And if we find certain genomic mutations, we can match them to targeted therapies that may overcome that resistance that aren't necessarily FDA approved, and so to provide access to those treatments that are really precise to try to shrink cancers and be kind of the next wave of approvals for patients with lung cancer, or to overcome resistance to existing treatments. And then if they're unmatched to those mutations, then immunotherapy can be beneficial. And we have a clinical trial that's adding on to pembrolizumab, that immunotherapy I mentioned before, an interleukin superagonist called N803 that helps stimulate the immune response to help juice the immune system to get back to attacking the cancer. So that's one example of a clinical trial at UC Davis that my colleague David Gandera has been instrumental in developing, and we've really supported and have some exciting arms. Like I said, it's precise, so depending on what mutation you have or not, to get immunotherapy versus other targeted therapies. So I would highlight that as an example of a clinical trial we have at UC Davis that we're excited about with immunotherapy. I also wanted to highlight a trial that I'm really excited about that is for patients with metastatic non-small cell lung cancer whose tumors express a high amount of a protein called PD-L1 that we think may make the tumors more likely to respond to immunotherapy. And we have a clinical trial that's combining a drug called pembrolizumab, which is approved for patients like this who have high PD-L1 expression in their metastatic lung cancer, and it's adding a vaccine against that PD-L1 as well as a protein called IDO that we think makes the tumor environment immunosuppressive, so the immunotherapy can't act optimally. And so this combination of PD-1 antibody, one like pembrolizumab, was studied in melanoma in combination with this vaccine. and over 40% of patients had a complete response. That meant no detectable cancer on their imaging. That was published in a prestigious journal called Nature Medicine. And now we're taking that combination of the PD-1 inhibitor that's approved and combining it with this vaccine in non-small cell lung cancer. And so based on the results in melanoma, I'm really excited to be able to offer this international clinical trial and this vaccine with the PD-1 immunotherapy to our patients here at UC Davis. It's open. It's open and available to patients, and we're really excited about developing this combination.
Well, that is exciting. How do patients sign up or get info about a clinical trial? Do they just speak with their oncologist, or do they need to bring it up, or do you bring it up? How does that work?
So that's a great question, Chris. Very few folks that are actually diagnosed with cancer go on to participate in clinical trials, and there's varied reasons for it, but one of it is not having enough information. And so, I think getting information, asking if their physician thinks their referral to UC Davis for clinical trials would be right for them. We also have outreach for early phase clinical trials. My colleague Chris Curl is a fantastic navigator and helps manage our phase 1 program. You could also call our office and ask, like I said, for an appointment and speak to somebody that's interested in that you're interested in clinical trials, and we'll work to make that happen. So I would encourage patients to think about if clinical trials would be right for them, and we certainly have some very promising ones here at UC Davis.
And again, with that robotic-assisted new procedure we have, we can diagnose lung cancer and remove the tumor in one procedure, correct? So no longer is there this time of, from diagnosis to months of being able to do something about that cancer. We can just get right on it, and it sure saves the patient a lot of angst, as they wait for a second surgery. Mm-hmm.
Absolutely. So, I mean, we really try to bring cutting edge treatment to patients to get them the best outcome possible. I have patients on these targeted treatments for years and years and years. I have patients on these immunotherapies for years and years and years. I have patients who've completed metastatic cancer, completed their course of 2 years of immunotherapy, or even stopped earlier, and their cancer hasn't come back. Now, we're not always able to do that, but we are able to bring patients the best treatment, both standard and on clinical trials, to try to get them the best outcome as possible, to help them, live as good for as long as possible. And I would highlight, on the earlier stage side, we have a great team of thoracic surgeons, interventional pulmonologists, radiation oncologists, to help provide the optimal chance at curing lung cancer when it's in the early stage or when it's not become metastatic. And, for example, from everything from our robot-assisted bronchoscopy, where we just did our 100th case to not only biopsy the tumor, but potentially treat the tumor, all the way to, integrating these treatments that we've had for metastatic cancer, such as immunotherapy and targeted therapy, and bring them up to the earlier stage setting to integrate those into our multidisciplinary treatments to try to get patients the best outcomes possible.
And it sounds, just by the tone of your voice, that there's hope out there for these lung cancer patients. I mean, it's still the number one cancer killer in the world, not just in the United States. And these are devastating cancers that can be very difficult to treat, but it sounds like there's a lot of hope on the horizon, and we're creating some miracles right here all the time.
Yeah, our interventional pulmonologists have really led the way on that. And like I said, we have a great team that I think of what's unique about UC Davis as a comprehensive cancer center is to have a team that primarily focuses on lung cancer day in and day out. So our interventional pulmonologists, their main focus is lung cancer, not other pulmonary conditions. They're excellent at that too, but they're able to really focus and bring that expertise to our patients.
Shifting gear just a little bit, from an educational standpoint, kind of informational at least, there is small cell and non-small cell lung cancers. Can you tell us what is that difference, and how is it affected, and also do different treatments and different therapies work in different ways with that?
So that's a great question. In terms of small cell versus non-small cell lung cancer, there's different types of lung cancer. What we do generally is a couple of things. Anytime for any cancer, whether it be lung cancer or any other cancer, we ask two basic questions: what kind is it, and how far it's spread. And so, what kind is it? Non-small cell lung cancer is about 85% of lung cancer. 15% is small cell lung cancer. That's rarely treated with surgery. That's more chemoradiation or chemoimmunotherapy. We have plenty of clinical trials and great expertise in small cell. Non-small cell lung cancer is the bulk of the lung cancer. Like I said, 85% of what we see, maybe a bit higher at UC Davis, but across the country, about 85%. And there's different types of histologies, so how it looks under the microscope. So there's the small cell, that's like these small round blue cell tumors, and then there's non-small cell that could be adenocarcinoma, form glands, squamous cell, they have a different appearance, sometimes large cell or neuroendocrine histologies, and then we break it down from there. So that's, for years, that's all we really did. But now we've got immune marker testing to stratify. Do you give immunotherapy alone? Do you give immunotherapy with chemo? And like I said, this gene sequencing, this broad gene precise profiling of the cancer to try to find what I like to call are game changer mutations, where there's a mutation, not usually within you, but within the tumor, that we can match to an effective targeted therapy. And that's how we approach taking care of patients. What kind is it? How far is it spread? And what are some of these game changer things that we could find to get the best treatment to the patient?
And what are the symptoms that somebody should be looking for when it comes to lung cancer?
So symptoms can be wide range. So, kind of and oftentimes not specific. So, cough, some breathing difficulty, those are usually the symptoms. Feeling more tired than usual, weight loss and not wanting to eat. Sometimes it can spread to the brain and people can get headaches or other neurologic changes, and sometimes it gets spread to the bone where they get bone pain. And so, it's a wide variety of non-specific symptoms. And I would urge anybody, like I said, sometimes a cough could be, a virus, but things that aren't getting better or getting worse, or, I'd encourage people to see their doctor.
And, UC Davis Comprehensive Cancer Center, we are so focused on making sure that the underserved get access to lung cancer screenings, and that they also receive the messages, the educational messages that we're trying to put out there, because we do see more lung cancer in the African American population. And also it was kind of interesting to learn that non-smoking Asian American women, we're seeing lung cancer in those populations. Why is that, do you think?
That's a great question. I could go on for a long answer, but I would start with the latter portion in terms of, our Asian American women do have a higher rate of having mutations in this gene called EGFR, stands for epidermal growth factor receptor, and they could have mutations that make it sensitive to EGFR inhibitors. The one we most commonly use is a drug called osimertinib. So we really want to, get, and we could even give it in the curative stage to help improve the cancer from coming back. So that's another area at UC Davis we're really focused on, advancing and making treatment better for those patients. It's in process to develop screening protocols for patients who haven't smoked. And so there was one done in Taiwan, that showed an increased incidence in those patients. So we're looking to take that to the U.S. Now, what causes it? We still don't know. There's been some recent, in terms of lung cancer in never smokers with these mutations. There's been some active research that it may result to kind of sensitivity to air pollution, but we're still trying to learn out more. And then, to answer the first part of your question. So in terms of our African American patients, that's something we of course need to improve screening rates on, but also, addressing healthcare disparities in those patients across the board, not just screening, but when you find the lung cancer, getting patients in, getting folks in quickly, delivering the best treatment, delivering the optimal treatment. And so that's another area that my colleague, Dr. David Cook, in thoracic surgery has really been working hard to address. And we're basically at UC Davis focused on all fronts to improve lung cancer care and treatment with a particular focus on improving outcomes among vulnerable populations.
And speaking of addressing cancer disparities, especially when it comes to lung cancer, which is one of the top priorities we have at the UC Davis Comprehensive Cancer Center, is to try to address the cancer disparities we're seeing in lung cancer patients. New federal guidelines, these are screening guidelines, should help, right? I mean, African American people, women, and younger smokers, it looks like they're going to have better access to these life-saving lung scans.
Yes, absolutely. So recent federal guidelines have revised the age at which to commence lung cancer screening from age 55 down to age 50. So patients 50 to 80 years old who have a 20-pack year smoking history and either currently smoke or who have quit within the past 15 years would be eligible. And so hopefully, that would help somewhat to help address some of these disparities, especially folks that may be predisposed to lung cancer at an earlier age. So once again, I would encourage everybody who's had a history of smoking to talk with their provider if lung cancer screening would be right for them, particularly those patients' age range and smoking history that fit within those guidelines. And so that's something here that we're establishing a comprehensive screening program to help detect lung cancer. And so, that program is led by my colleague David Cook in thoracic surgery and Dr. Fan in interventional pulmonology. And so we have this program, but patients, as you mentioned before, very few patients who are eligible actually get screened. And my colleagues there at our multidisciplinary Thoracic Oncology Program are really focused on increasing the rate of screening in our community, especially among vulnerable populations that are likely at increased risk for developing lung cancer. And that's something that's really important to us, and integrating that with not just the detection, but smoking cessation, which is the biggest thing you can do to help prevent lung cancer, and into our multidisciplinary Thoracic Oncology Program in terms of when we find patients that need our help to get them the quality care that they need quickly.
And we've just opened up a study. This is how serious we are about getting patients in. We've opened up a study that's available to any UC Davis patient who can, if they want to participate. There's even a gift card involved as a thank you for doing an interview and talking to our researchers about why they have been hesitant to come in to get screened. And mainly we're going to be talking to smokers and former smokers, but that's how seriously we take it here, that we want to increase those lung cancer screening rates, because 1% of eligible patients is just not enough. We need to get those rates way up.
Absolutely. We really want to meet people where they are to help find out why there may be hesitancy, and to help address that and get more patients to do lung cancer screening, because it could save their life.
Go to our study pages, go to UC Davis Comprehensive Cancer Center to the newsroom, and you'll see on World Cancer Day, we announced the launch of this new lung cancer screening study. And if you want to participate, just click on that information and give us a call.
Thanks for highlighting that, Stephanie.
All right, Dr. Riess, is there anything else additional that maybe we didn't touch on that you'd like our listeners to know about? I would just, I really appreciate the opportunity to come on and talk with you both
about our thoracic oncology and lung cancer program, I would just say we've got a great multidisciplinary team to help bring cutting edge treatment to our patients. And so that's something I would just really emphasize and appreciate the opportunity to get on this podcast and talk about it.
Well, we appreciate you sharing your expertise with us. Thank you for joining us. And we thank you for tuning in and listening today. If you'd like to get in touch with us, you can email us directly at beatcancer@ucdavis.edu. Beat Cancer is a production of the UC Davis Comprehensive Cancer Center. For more information on our NCI-designated Comprehensive Cancer Center, please visit health.ucdavis.edu/cancer.